diagnosed. I mean, they have been documented. Who knows how many others exist that are not documented? Unless a pressure injury is present on admission and you, the nurse, document it. Because you the RN, right? You do the assessments, right? If you don't document it upon, patient comes in from the nursing home and your initial assessment does not indicate that they had a pressure ulcer, now, in the past couple years, Medicare will decline payment for that treatment. I tell you, it's costly. Costly. Which I think it's a little unfair. We should take care of our patients and pay for that. But what's wrong is federal government's out of money. It's very costly. The decubitus ulcers, infections that are incurred as a result. But the cost in lives are great. 70%. Can you imagine people die of a decubitus? Let me tell you, Christopher Reeves, Superman, right? Mm-hmm. Riding the horse in Virginia, fell off the horse or whatever. The horse got spooked. He developed a high, I guess it's C3. I don't know what the fracture was, which paralyzed him. But what really killed him, I will tell you, he had all the help he could get, but it's so near impossible to keep a person from developing decubitus type areas. Because he hadn't, unless someone moved him, he didn't move, you see. I can imagine he had a tunnel decubitus that developed. And when you start getting these real bad septic decubitus ulcers, they do start impacting other organs, which resulted in problems with his heart, right? You got to imagine what happens, because the skin's an organ too. One organ failure leads to another, Yeah. I probably don't, but I'll tell you to look it up and share it with the class next time. They're the size.
Okay, the reason Medicare don't pay for it, do they encourage the client then to sue? Is that why they're not paying for it?
No. I have no idea. I think we're bankrupt.
Will the hospital then pay for it?
I think we're bankrupt. Oh, yes. The hospital incurs the cost.
Oh, okay. The patient's not incurring the cost.
Is that when they're dropping some places like Blue Cross Blue Shield right now?
Huh?
I heard some places are dropping Blue Cross Blue Shield right now because they're not paying out.
Yes. Oh, Waylon needs to change their insurance.
Yeah, I got Blue Cross Blue Shield too.
Yeah.
I ain't heard that one.
Yes, they did, didn't they? Yeah, it's tough.
And is that
So they don't gotta, you don't gotta sue nothing. You just don't have to pay if you get decubitus ulcer.
Oh, they will charge you. The hospital will send you a bill.
So you pretty much gotta sue.
You can't, I don't know about the suing thing.
They make you sign this statement when you go in there. If your insurance company does not comply with it, you are responsible
Here's
for
what
the
you got to
remainder bill.
remember. You've got to remember to study. This is your insurance. Study your insurance and study your hospital. You got to make sure you guys do that for your own protection, your own family's protection, and make sure that hospital has agreement that they will accept whatever payment that insurance company provides, and you go to their hospital. Mm-hmm. See how that works? See what I'm saying?
You go to a hospital.
You got to be smart about this. I used to tell my son, now, if you get sick, you're going to have to travel down here to this particular hospital. You're going to have to hold on because we're assigned to this hospital. In one of my places I worked at, and I had this kind of insurance policy. you gotta know these things, guys. Up front, you gotta understand what hospital you should be taking your family to. Investigate this stuff, because it could be extremely costly for you and your family, you see. Never be caught without insurance, guys. Just don't. It could wipe you out financially. One hospital stay could, and doesn't take long, 1 week. Dawn could attest to the cost. Probably that experience with your husband, 150,000 probably. I don't know.
We normally don't have insurance when it started, like 3 months earlier.
Zinc.
Yeah.
So,
Oh.
insurance.
Lucky.
First time we'd ever had it.
Lucky. It could wipe you out. It would wipe you out. So you guys, if you don't have insurance, which all of y'all should be carrying something, you get yourself over there to CareLink quickly. It's not really an insurance company, but it's a payment system. You know, you do, the only thing I say, and Brian, you're supposed to email that, remember you told me you was gonna do it, that person in the Pentagon. Did you do it?
I have, no, I
Yeah.
told you they moved a lot of my people that were.
No,
doing
you gotta,
work.
I want you to still do it.
I'll see if I know anybody who
I
works.
don't care, just email somebody. What I'm speaking of, you know,
something.
we're talking about this Obamacare, and I think it's good that we make sure everybody has insurance. I'm not political one way or the other, I don't care, because it's just the figurehead in that office. But when it's a national insurance thing, I want to make sure that we don't forget about dental care. That's what I think is the demise of people. Yes, the dental care can lead to overall poor health. Dental care. Don't forget. Don't forget.
I'm gonna call them up.
Okay,
I
I
don't
want
have
you
AKO
to do.
anymore though.
Nah, you just get in there some way or another. It's a good project. We want to push for universal dental care. Very important, because that's one thing they don't talk about. They don't want to talk about it, because you know why? That's expensive. Because you can go to the hospital, to the ER, say, I'm having chest pain, they're going to treat you, right? But you can go, if you go to the hospital and say, I've got a toothache,
Probably don't really get ice.
what are they going to do for you?
Give you a big fat bill and refer you to people.
Yeah, but refer you to what though? University dental school that won't take you, or they'll give you some painkillers and send you on your way, but it's not, and maybe some antibiotics.
3 or the next
You see what I'm saying here? You, each and every one of them know exactly what I'm saying.
niacin. And the
That
last
should
one
be
is the
that should be y'all's project to figure out how to push to get the universal dental coverage. I'm a big proponent on that.
Sure.
So let me, here I drew another little, I'm getting good at these diagrams, guys. You like it? See how that, just in one picture, you can understand it.
Getting better.
I am. I'm learning how to move these boxes and circles around.
Here it is.
Y'all are my first group. I've been playing around with that kind of thing.
That last one was not scary.
Yes. Well, it was, because that was Mr. Moore. It's always scary when it's Mr. Moore.
Was the
Right.
inner.
Mobility and sensation.
Nobody calls it the
Time and pressure. You let a person lay in one spot too long, you can develop that pressure ulcer. You have intrinsic factors such as nutrition, age, circulation, underlying health status. And you have these external factors. Friction, shear, moisture, bony prominences. And you put those two together, that too leads to pressure ulcers. So there you have it, nutshell. Pressure ulcers, classified by degree of tissue involvement. But remember this, reverse staging does not occur as an ulcer heals. In other words, if that's been identified as a stage 3, it's not going to become then, once it's starting to heal, stage 2, stage 1. Once it's diagnosed as this, it's what it is. And there I tell you, even though a pressure ulcer with proper treatments heal, the proper term, as in the above stage 4, it is described as stage 4 ulcer healing. I used to think otherwise myself until I met this at a nursing home that I took students to, where I'm still taking, they have this relationship with University Medical School. And once a week, this wound care physician actually comes out and makes rounds at this nursing home because they've developed this relationship. It's like a pilot test or study to cut down on the amount of developing decubitus in a nursing home. And I literally, he had a class for my students. It never changes once it's diagnosed as a certain stage. That's what it is, always, always. So somebody that finally gets healed and goes, when they go home, they're still with that diagnosis. Stage 4 ulcer healed. See what I'm saying? If they've gone home totally, it's still, they've got that diagnosis. And I say to you guys, please refer to that table. I could foresee in state boards that they could actually give you a description and an illustration of a decubitus. Because they got that ability now that they've got computerized testing. They could give you a picture and a descriptive with that picture, and they would say, now you identify what this stage is. Can't you see that as I could see that as an in-class.
So is that because once you get a pressure ulcer in a certain spot, you're more likely to get it there again?
Yes, yes, that's what they say. That research says that. So we're going back to this story, and let us cut this light off because I want everybody to see. Remember Mr. Moore? And I'm referring to this part here that we really can't tell what that is. What that would be stage death. And what the answer will be is unstageable. Unstageable. You might see that next week, but I won't include the photogenic. You will never forget it though, will you? Unstageable. Unstageable. This is that's bad.
That's because of the color.
It's just the whole condition. We can't say the damage. It doesn't look like it goes right to the bone, but we can't really tell because of the condition of it. See? Oh, but remember I told y'all about the story of the lady. Her whole backside. You have to understand, not just backside, her bottom of her legs all the way to the back. See, can you imagine what I admitted that day? I literally, when I did my first dressing change, and I told you I had 3 of those air fresheners running in that room full blast. And I was in my isolation with the mask. There was no isolation, but I was, because it was like, it was death. That's the closest I smell the smell of death. You know, sometimes you see animals hit on the road, and you go up and you move them over, and they've been there for a while, and you know that smell of death. That lady was alive, not on a ventilator. She had a 100% non-rebreather mask on. She had vasopressors because she really literally had no blood pressure. That was death. And she was alive. And it was such a horrendous experience. I'll never forget it. But her whole backside, the back of her legs, shoulder blades, back of her feet. That, except when I did the dressing change and I started irrigating, I literally started seeing bone. Literally. She lived maybe, like I said, I think it was a couple days. She survived a couple days. Not that she was awake and responsive for us, because she'd already gone not responsive. But not to make y'all just gross you out and make you so sick. I just want you to know that these things happen. these things, it was, she lived in a neighborhood and no one, the mailman was the one that uncovered this because the habits of the person was to take the mail out. And for 2 or 3 days, the mail had not been taken out of the mailbox. You see the power of the mailman. See, you can imagine, right? That. Venous stasis ulcers, we talked about that. That's typically tied to what? Chronic condition, damage of the valves in the veins. That's a chronicity of health care. Sometimes you see these DVTs after patients undergone cardiac surgery as what they'll do, sometimes they'll graft and harvest those veins from the lower extremities. So sometimes you see that because veins are sort of stretchy. They're like cooked macaroni, right? When you think of, and you're going to hear this again, I love some of the things I've learned from Miss Pryor. You guys probably have heard of Miss Pryor, maybe not. She's tough. Y'all have already heard that, haven't you? Dawn shakes her head, yeah. She knows. She's heard from others, haven't you? But I tell you what, she's smart. She's an ICU nurse. She's a colonel in the military. But her ranking, she went up through the ICU. So she's seen everything known to man. She's seen more than I've seen, let me tell you. She talks about having a hatchet in somebody's skull. I haven't had, and it's in place as she receives the patient. But she gave the students a good explanation. I loved it. When you think about the difference between arteries and veins, that go home and take out macaroni, elbow macaroni, and that uncooked macaroni, that depicts the artery. It's very strong, rigid. It's the one that takes on the force of the heart pumping the blood, right? It's got to be strong. The arteries have to be strong. And then the venous is our low pressure end. It's coming back. It's sort of passively coming back to our heart. Venous side, it's like the cooked macaroni. Soft. You'll hear that again. I'm sure it's coming to you. Adult Health 1. But you can imagine what they do. They harvest part of the vein from the leg for the bypass surgery. And they can, of course, reanastomose, that vein. When you think about DVTs, you're going to remember as you do your assessment, legs going to feel warm, it's going to be tender. Typically in the calf region, if you talk about these lower extremities. You may have, see these nodules? Y'all can see that, right? I know it's got the break, but you see, I could show you mine, and maybe some of y'all could have these appearances of these varicosities. Have y'all seen the varicosities in some of your patients? Varicose veins? You see what I'm saying? We as we get older, we develop disease states. That's why I ask each and every one of you, male or female, to make sure that in your practice, don't do like me. Please know that you're going to work in a hospital. It's going to be concrete floors. Wear those patient head hoses. Head hoses are just not for patients. They're for nurses. I'll have to invent those. Call them something, nursing head hose. So I'm thinking of all these things. Well, I forgot the other thing we're going to invent. The bottle for the nursing home patients. See, I'm coming up with my whole line of things, right? You could help me. Are you good at advertising? No, because you haven't even got the help. You got to do that dental thing.
That's a negative.
Nah. I might need to consult my first cousin, because I told some of y'all what he invented was the with the insulin vials. He was years ago. I'd say 30-plus years ago, after he graduated from University of Auburn, he worked as a medical representative, a drug pharmaceutical medical representative. He would go in to these pharmaceutical factories, and for this one company, he would hear this popping sound, pop, 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 and he would ask the person that was taking him through the factory, well, what's that sound I hear? Well, those are the vials of insulin that the bottle, the rubber stopper doesn't take. Because at the time, they did not have this ring. It's a simple ring that goes around the top of the insulin vials. They didn't have that. That's something that simple. You know, like to keep the, you know, something like this little thing. I'm trying to show you the simulation, but it was something like this little ring here, right? See what I mean? So he invented that. He patented it. Now it's on all insulin vials across the world. Millionaire over and over. He keeps his money. He doesn't share it. Not that close. He's my first cousin. That's what he invented. See how you can invent things? Something that simple. Because nobody had figured out how to keep those rubber stoppers inside those insulin vials. So he worked on designing that, and $50 million later, he sold his company. You know, it was bought by a NASDAQ recognized company. And he gets to golf in his goal was to go golfing in every golf course in the world, or I don't know what it was. But see, nurses do invent a lot of things because why? We're taking direct care of our patients and we see issues. We see problems. We have to be creative. You guys, any one of y'all could do that. As you're taking care of patients, you see something, you say, you know, let's try this. And then we find that it leads to successful outcomes. Patients with poor circulation, they are most at risk for pressure ulcers. People who use tobacco, they are constricting their blood supply. And at first I couldn't believe I found this. I said, oh man, let me stick that on there anyway. So we know we're not going to be smoking and have oxygen at the same time. The answer is smoking cessation. Smoking cessation is the answer to all things. You can limit alcohol. You can limit alcohol, but you always have smoking cessation. Most commonly used tools that, and y'all may have seen, and each nursing home might have different ones. Hospital might use, but mostly hospitals use that Braden scale. These, when you go to those websites, that depicts the picture. That's not a YouTube. These are pictures. The other one your book identifies is the Norton scale. But that came after the Braden scale, and it actually is similar to the Braden scale. The one that I would say that you might see on state boards is that Braden scale. That's the one that we've seen that over and over. That's what they use in the hospital. And I'm sure Ms. Algazay's probably talked to y'all, or maybe not, I don't know. She leaves it to me maybe. But that picture, when you click on that web link, that will show you an example of a Braden scale form. Types of tissue in wound beds. Slough. Slough just sounds soft and moist. Right? Eschar. Necrotic. Eschar is darker. Granulation tissue. Granulation has this pebble type surface, and you can see it looks sort of pebbly. And then I could not find what a clean non-granulated surface would be, but I can imagine that if this without the pebbles, you see. Some of the nursing diagnoses that you would be familiar with, of course, it would be risk for impaired skin and hair related to immobility. That's something you would see typically for people that have, or patients that have risk for skin breakdown that don't have as good a mobility. And then, of course, the goal for an open wound would be written something like this. The wound will remain free of infection throughout the healing process. Now, you guys have short-term and long-term goals in your nursing care plans, right? And I say to my group, and I give the same comments because y'all all have the same questions that my group's gotten. When you have short and long-term goals, you got to make sure that these goals are measurable. Measurable. In terms of short-term, it's time sensitive, and long-term is time sensitive. Short-term, I have a patient that comes in through the ER and they feel weak and dizzy, and they hook them up to the monitor, and lo and behold, because y'all gonna have this next week, electrolytes, they have an irritable heart. They're having irregular heartbeats. And we draw labs and we find that that potassium's low. It's 3. You guys are gonna learn the normal values of your potassium. So the short-term goal would be within, by the end of my shift, patient's serum potassium level will be 3.5. Patient will have decreased cardiac irritability, meaning less premature ventricular contractions, to a rate of less than 6 per minute. Because maybe they came in and they were having like 12, that's why they were so dizzy. I don't know if that outcome will be met or not. It might not. So then we have to revise it. And then the long-term goal would be something read like this. Prior to discharge, patient will be able to express foods that would be high in potassium, understanding of medication regime. And when I say foods high in potassium, then I would list those foods. Because on state boards, I will tell you that they will give you a food selections. You'll have to say what the leafy green vegetable is high in.
Okay.
You see what I'm saying? You see, that's how they're going to do that on state boards. Select all that apply. See, and they'll give you all, select, you know, whichever ones, whatever the nutritional value is for whatever. All right. Nursing interventions prevent. Well, what we should do is what? We always do what? We assess. We assess and we reassess for all patients. Book says daily, but I'd say every 4 hours. I think at least every 4 hours. Remember, you're changing your patient's position at least every 2 hours. You may not be doing it, but you might have to delegate. Now, if you notice any kind of redness on this when you change your position of Mr. Moore, please inform me, because you delegate. See, now you're not telling them to assess. You're saying if you observe any redness, right? They can see it. They can tell you. You go and you'll do your assessment. Manage that moisture. And optimize the hydration, hence the bottle. See, we're going to invent the bottle, the water bottle for all of our nursing home patients. And nutrition. Protein supplements. Some of you guys got to see that where they give that ProMod or protein powder, protein sprinkle for their patients to encourage healing of wounds or decubitus, right? You'll see that. Turning and reposition at least every 2 hours, and then you might have to go more often. Might have to have a more often turn schedule, right? And guys, common sense. Isn't that a bony prominence? That heel. That's why I give you the picture, because you won't forget. If I have my heel on this surface for 4 hours, solid, and I'm